So today I want to talk to you about how we use pilocarpine topically in the neuro-ophthalmology clinic to help us with patients who have anisocoria. So anisocoria means chorea means pupil, iso means same, and an means not. So not same pupil, anisocoria. And pilocarpine is testing the integrity of the parasympathetic nervous system, not the sympathetic nervous system, which would be the Horner syndrome. So in the parasympathetic related anisocoria, the pupil anisocoria is greater in the light because the involved pupil has a decreased light reaction. And therefore, when you have the normal pupil constrict, the anisocoria will be increased when you have the light. That's the opposite of the sympathetic nervous system, the Horner syndrome, where the anisocoria is greater in the dark. And so when we're confronted with this situation right here, the first thing you need to make sure that it's not a third nerve palsy. And the way to do that is not with these drops. The way to do that is to look for the ptosis and the motility deficit. So if it's an isolated pupil, then you can be relatively assured that it is not a third nerve palsy. So once you have this isolated dilated pupil, the second thing you're going to do whenever you have a light reaction that is decreased is you're going to check the near reaction. And so if you have a light reaction that's poor but a near reaction that's good, and if it's tonic, then you actually don't need pilocarpine anymore, because this establishes the diagnosis of the tonic pupil. There may be sector paresis or vermiform movements of the iris, and you should watch the Addis tonic pupil video for that. However, if you did want to test this pupil, we would use 1/10% pilocarpine, and in a tonic pupil, including the idiopathic variety Addis tonic pupil, 1/10% pilocarpine will constrict this pupil because it's demonstrating upregulation and denervation supersensitivity to 1/10% dilute pilocarpine. So this would confirm what you already know clinically, that this is a tonic pupil and probably Addis tonic pupil. However, sometimes the pupil is big and poorly reactive to light and doesn't react to near. So if it neither reacts to light nor the near, then one of the things that could be causing a pupil to be larger and the anisocoria to be greater in the light is that this pupil is pharmacologically blocked with a parasympatholytic like atropine or scopolamine, because they have a scopolamine patch or something that's dilating their pupil. And so the test there is we're going to put the 1/10% pilocarpine in first to make sure it's not an acute Addis tonic pupil, and that's because the near reaction might not be there yet because it's too acute. If you have no reaction to 1/10% pilocarpine, then we're going to put in full strength 1% pilocarpine. And if it doesn't constrict, that tells us that this is pharmacologically blocked. So the 1% pilocarpine shows no or poor constriction in the pharmacologically dilated pupil. However, you should not use the 1/10% pilocarpine to differentiate third nerve palsy. That's done with the ptosis and the motility. And in fact, any cause of denervation, whether it's third nerve palsy or the tonic pupil from the ganglion, will cause upregulation of the receptor. So you cannot use the 1/10% pilocarpine to differentiate third from tonic pupil. We're using the 1/10% pilocarpine to document that it's a tonic pupil after we make sure it's not a third with no ptosis, no motility deficit. 1% pilocarpine is to make sure it's not pharmacologically dilated from parasympatholytic agent. However, you cannot use this for sympathomimetic related mydriasis because that's the wrong side. So that's epinephrine. You cannot use this pilo for sympathetically mediated dilation. And so you need to know a little bit about pilo and its topical testing.